I am Shri Cora. I'm one of the radiologists at Loma, and I work almost exclusively in breast imaging. And I'm just going to talk to you a little bit about screening tests for your breasts. Which one should you have, when, and why? So why is breast cancer screening even necessary? As you can see on this slide, we all come in different shapes and colors and sizes, but they're all breasts up there. We have them and we have to take care of them. Different things can happen to them, be they not cancer or cancer, but either way, we have to deal with it. So a little bit before we go into screening about breast anatomy. Now, I'm sure you've seen your own breasts from the outside. Whether you're impressed with them or not, I don't know. But inside, we have things called ducts, right? These ducts are what carry milk when you're breastfeeding. And these are the little pink lines here. They come out at the nipple. On the other end of the ducts are lobules where milk is made. Now, around that is basically the yellow fat and some connective tissue. More fat is normally what happens in your breast when you get older, but when you're younger, there's a predominance of the fibroglandular tissue, which is stiffer, basically, and it's also harder to see through on mammogram. Now, within these ducts is where the majority of breast cancers occur, and I'll use some terms such as in situ, meaning inside the duct, versus invasive, which is something outside of the duct, getting into the tissue surrounding it. Some cancers do actually start in the lobules as well. Now, just for your information here, if you take one of the ducts and you cut them in half and look down it like a straw, you would normally have some cells in a circle. Okay, that's just what a normal duct looks like. Now, if you get hyperplasia, meaning overgrowth, you get extra cells in there. Now, as long as they look like the other cells and there's not too many of them, it's not a big problem. Now, when you start to get extra cells and they look a little different than the other, that's something that the pathologist would call atypical ductal hyperplasia. That doesn't mean cancer, but that does mean that a surgeon will probably go take a little extra tissue to investigate. Now, we have what's called ductal carcinoma in situ, meaning ductal, in the duct, carcinoma, cancer, in situ, still inside that kind of straw-like duct. And eventually, if time keeps going, they start to poke their little heads through the edge of the duct. That you can have a little bit of a head poke, that's called microinvasion. Now, when they start to get a little wild and just leave the duct, that's called invasion. So, a few breast cancer facts. Breast cancer is a relatively common cancer, especially in women. And these in situ or in-place cases, there's almost 65,000 of them that happened as of a compilation in 2013. Invasive cases, unfortunately, there are more of them, almost 233,000. Oops. And unfortunately, nearly 40,000 people died as of in the year 2013 from breast cancer. So what can we do about this? How can we combat this? First thing is to have a breast exam. Clinical breast exam is done by a clinician or a doctor. And starting at age 20, you have them about every 3 years, okay? Because at age 20, the likelihood of you having breast cancer is relatively low. Now, once you get to age 40, you're increasing with time, your risk, and they say that you should have a breast exam every year at 40, starting at 40. Now, this BSE, the breast self-exam, you can do whenever you want. They often encourage you to do it monthly at the same time in your cycle so that you have a common thread and you know what your own breasts feel like. Now, if you don't like doing it and you have a significant other who would like to, somebody should know what your breasts feel like so they know if there's something new. So, screening recommendations that are out there. The average person who just has breasts but doesn't have anything else going on in their family or other things that we'll talk about. So your average risk woman. You need an annual mammogram beginning at age 40. A couple of years ago, there was an agency that put out a statement that said, no, you should start about age 50. I wouldn't do that. So Susan G. Komen, the American Cancer Society, the National Cancer Institute, all feel that you should begin at 40 and have them every year. Now, they talk about modest benefits, meaning sometimes when you get a screening exam, you get called back because they see something on your mammogram. Then they're not sure and they see something on your ultrasound, and then you end up with a biopsy. And after all that, it's not cancer. That's called a false positive. And so when they do research, they try to weigh, is the benefit of the test worth the anxiety of the false positives. And most people would agree that even between these early ages of 40 to 49, it is, because yes, there are false positives, but you also catch early cancer at those ages. Now, when you get 50 to 69, there's a clear decrease in mortality or dying from breast cancer based on screening with mammogram. As you get older, over age 70, most major health organizations will still tell you to get mammograms. Now, the American College of Radiology has a strange statement that says you should get them basically up until 3 years before you're going to die. Now, how you're going to know that, I don't know. But, unless you're psychic. The best thing to do would be to consider how healthy you are. If you're relatively healthy and you think that you want to live, then get a mammogram, because you sure don't want breast cancer to interrupt that. If you have major health problems and you think you're dying from something else anyway, a mammogram might not be quite as important. So, a word about mammograms. I have people who come for other tests and say they don't get mammograms because of the radiation. There is radiation everywhere. And yes, if you cumulatively look at mammograms over your life, there is a tiny increase in risk, as opposed to someone who never got a mammogram. But again, the benefit of detecting a cancer is much higher. So cumulatively, they predict that you have about a 0.1% increased risk. Compare that to the 1 in 8 women who get breast cancer anyway, at 12.5% risk. So it's much lower, and I just suggest you do it. It's not going to give you cancer. So, a little more about risk. So there's what they call relative risk. So it's relative to the average person. So if you look at a few of these things here, you can see that greater than 4 times the average risk is when you get basically over 65, because everything increases risk with age. If you've had atypia on a biopsy, if you have certain gene mutations that we'll refer to later, if you've had lobular, like I said, there's lobular cancers, dense breasts, which we will also talk about later, a personal history of breast cancer below age 40, because that would be an early onset, or 2 or more first-degree relatives, meaning daughter, sister, mother, with breast cancer diagnosed at an early age, before age 40. There are other things here that also increase your risk, but to a lesser extent. Things that you can't control, like your ethnic heritage, are just there. But outside of that, what they say high risk is really what is in the greater than 4 times risk category. So, what are the screening recommendations for these high-risk women, right? So again, we're going to talk about the gene mutations, the BRCA 1 and 2. There's other ones, there's lots of other little names for gene mutations, but we won't get into all that because it's just minutia. Or if you have a first-degree relative with a mutation, your strong family history, like I said, personal history, and also radiation treatment to your chest. If you had a cancer and they had to give you external radiation to treat the cancer, you're at risk because of that. So we won't go through all of these because these charts are small print. But for example, if you had lobular carcinoma in situ, or if you had atypical hyperplasia, meaning not cancer but atypia, if you want to look at your clinical breast exam, instead of doing it yearly, they would consider doing it every 6 to 12 months. Get your mammogram every year. And the last column is for adding MRI. Now, some people get very excited about MRIs, but there's only certain situations that it's useful for. Again, here, a strong family history of breast or ovarian cancer. If you're under age 25, they're still going to say go ahead and get a clinical breast exam every year. But see, the middle column, mammogram is not recommended. Why? Young, dense breasts. You don't see well. And MRI is still not recommended. If you've had the radiation treatment, you're looking at getting every year clinical exam. If you're over age 25, you're going to be more frequent because you're further out and more likely the cancer will occur from there. And you can get an MRI over age 25 starting about 8 to 10 years after the radiation treatment was completed. Now again, I'm not going to go through every one of these. These are on the Susan G. Komen website, so if you want to refer and try to find yourself in the chart, go ahead. About these BRCA genes. So BRCA comes from BR, breast, CA, cancer. 1 and 2. These are genes in your DNA, which you're made up of, that control certain either protein synthesis or just things going on in your body. And when something goes wrong, they get mutated, right? They're not normal. And so you can tend to get more breast cancer. So these are the most well-known genes linked to your breast cancer risk. They can come from either parent. And they're actually rare in the general population, even though you hear about it all the time in the news and on TV. But it varies by ethnic group. And this chart looks at the BRCA1 and 2 mutations in U.S. women by ethnic group. And you can see that, yes, there are some that have a relatively high percent chance, the Ashkenazi Jewish population. But outside of that, the prevalence is relatively low. So it's not as though everyone is just walking around with BRCA1 and 2 mutations. Your physician can look at your history and also your family history and see, do you need that kind of testing? So what happens with these BRCA genes? So a BRCA1 carrier has a 55 to 65% chance of developing breast cancer by age 70. A BRCA2 carrier, slightly less, at 45%. Now compare this to the average population has an 8% chance by age 70 with that 12.5% total life chance. So it is elevated compared to the general population, so it's good to know, but it's also good to know that most breast cancer is not hereditary. So please don't think that if your mother, sister, daughter doesn't have breast cancer, no one in my family has breast cancer, that you're not at risk, because just having breasts puts you at risk and you still need to get screening. BRCA1 carriers have what they call triple negative tumors. Tumors have these little cellular markers that describe them, basically. And the BRCA1 carrier tumor tends to have negative, missing all those markers, and it tends to be more aggressive, harder to treat. BRCA2 carrier at least has the one marker, ER positive, and makes it a little better to treat than the triple negative tumor. BRCA1 and 2 carriers also have an increased risk of another breast cancer, often in the other breast. So if you had right breast cancer, your risk is now increased, but it often happens in the other breast. And you can look, your average person who has breast cancer has a 5 to 10% chance of recurrence at 5 years, as opposed to 10 to 30% in one of the mutation people. So they can also affect organs outside of your breast. BRCA1 has a risk for ovarian cancer up to 35 to 70%. BRCA2 is lower, 10 to 30%, but you compare that to the general population's risk for ovarian cancer at less than 2%. So it's still pretty significant. They can affect men. Men have breasts. They may not like to think about it, but they're there. If you have a BRCA2 mutation, it contributes up to 40% of breast cancer in men, which is a higher percentage than in women. So more breast cancers in men are hereditary as opposed to women. A non-carrier's risk for breast cancer in a man is 1 in 1,000 versus 65 in 1,000 for a man with BRCA2 mutation. It also gives the BRCA1 mutation also gives an increased risk for men, but it's not as clear, the numbers. And BRCA2 carriers are also at risk for prostate cancer, higher than the general population. This slide is to remind me, now we're going to the fun stuff, the imaging. So she said, yes, I did have my mammogram today. Why do you ask? This must be what it feels like. They don't stay that way, I promise. It may feel like that. So what are our screening tools? We've already talked about the clinical breast exam, the self-breast exam. So then you come to me, and I don't do your mammogram, but I read them. But this is kind of what a mammogram is going to look like. So at the top, you have where your x-rays come from. They come down here. And when this paddle comes down on the breast, your breast is compressed to spread the tissue out and see better. And then the x-rays hit a little receptor down here that picks up the image. Okay? Then the image comes over either on a film or on the computer to the person who's going to read it. There's low dose for the x-rays. And let me talk about screening versus diagnostic. So a screening mammogram is for a person who has no complaints about their breasts, at least, no problems with the breasts, and they are just going every year to get a checkup. A diagnostic exam is when you've had a screening and they find something and you come back, or you just go to your doctor and you have something wrong with your breast, and then they go about doing a diagnostic exam. It has additional views from your regular exam, and sometimes hurts more because they press harder. Now, there are limitations. Mammogram doesn't catch every single thing, and you'll see why in a minute. But I have in bold, bring your priors. If you've had prior mammograms, please, for God's sake, bring them. or tell your place that did them before to send them, because they are like gold to a radiologist. They tell me, oh, that little piece of tissue, was that there before? Do I need to work that up? Do I need to call this unfortunate lady back? No, I don't. It's been there since 1982. It's just a wonderful thing to have as reference, and the more you have, the better, because every time you have a mammogram, things look just a little bit different because there's always a little difference in technique or the technologist doing it, so bring your priors if you have them. Breast density. So again, here's a mammogram, right? So here's a breast. You see the fat is black. The tissue inside your breast that's not fat is white, okay? So if you have a breast that's mostly black, it's almost entirely fat. You get a little more tissue, it's scattered density. You move over to the right, you get heterogeneously dense, increasing amounts of breast tissue until you get to the far right where there's a lot of white, okay? Now, I mentioned this because looking for cancer, cancer on the screen is going to be white. So if you have a black breast with a white cancer, it's very easy to see. If you have a white breast looking for a white cancer, it's much harder to see. And that is one of the main limitations of mammography, the amount of tissue that's in there already that will obscure something that's there. So what are some of the things that we look for on mammogram? Microcalcifications, small calcifications, right? These are the bad ones. So this would be microcalcifications that are grouped together that need a biopsy, okay? You compare that to these calcifications. They're bigger, and they kind of look like a food that many people like, popcorn. They're called popcorn calcifications. They go with a benign process. We see those on a screening mammogram. You're good for a year. So we are looking for those kind of things. We're also looking for masses. So here is the person's nipple. Here is a big white blob that shouldn't be there. Okay, this is a mass. It's got little fingers coming out from it. One of the fingers is reaching out and pulling on the person's nipple. That's nipple retraction, which you can see on your own exam. That's something that we would say, that needs a biopsy. So what about MRI? MRI is a new, well, relatively new, fancy tool, and people say, well, why can't I just get an MRI? Well, yes, it does pick up some areas. This happened to be an area of cancer in the breast. It's mostly reserved for high-risk women or in process for planning for surgeries, reevaluation of someone who already has cancer, because it's very sensitive, meaning it picks up everything almost. And in that everything, lots of things are not cancer, which means you get lots of biopsies, which means you get lots of false positives, and that makes people unhappy. It's also rather expensive, and so insurance companies want a good reason to do the MRI. So ultrasound. This is something that doesn't have x-rays, there's no radiation, it's not as expensive as an MRI. Why don't I just do that instead of a mammogram? Not a good idea. Number one, because those calcifications that I showed you a couple of things ago, you can't see too well on ultrasound. And those are the calcifications that you want to pick up early before it turns into that big white blob, okay? So it's not an appropriate screening tool on its own for breast cancer, except in very few cases, which I won't mention here because I don't think any of you meet that. Sometimes they'll use it as an adjunct or an extra screening tool with dense breasts. So if you have all that white tissue and it's hard to see, your doctor may say, well, you know, you have dense breasts, that's already something increasing your risk. Let's go ahead and get you an ultrasound and just check and make sure there's nothing hiding behind all that. It serves as an important role in distinguishing a solid versus cystic mass. So here is a picture of what's a cyst. Now, it would look white on mammogram. Now, so you'd say, is it solid or cystic? You do an ultrasound, you find that it's basically got nothing in it, it's got some brightness behind it, that's a cyst. There's no problem with that. If you want it aspirated for your own comfort, that's okay, but this does not need to be biopsied. Now this, you see, doesn't look as clear as the one on the left. That's a mass. This is also a mass. These things, the two on the right, would probably get biopsied. Also, if you have a palpable, you can feel it lesion. If you're below age 40, that is the first test to do. You say, I feel this, and then you come to the radiologist and they put the ultrasound right there and see, what is it? If you're over 40, your doctor's probably going to order a mammogram and an ultrasound because that's the appropriate workup. Something relatively new as well, tomosynthesis. It's part of mammography, but instead of just having the compression paddle come down, take one picture from top to bottom and one picture from side to side, the compression paddle comes down and the tube that's above you rotates from one side to the other, doing x-rays as it goes, and it gives you kind of a limited CT-like picture, multiple layers of images, and the radiologist can kind of scroll through that and separate some of that dense tissue. It's in no way perfect, but it does help. And it does reduce the rates for recall, meaning if I had a dense breast and I wasn't sure about a little area, is that a mass or not? Get one of these, which we have at Loma Linda. And we'll be able to say, oh, no, that's just overlapping tissue. Don't worry about that. Come back in a year. Less heartbreak. And the radiation doses for it still fall within the limits that are put out by the government. It is a little more radiation than a regular one, but still is not going to give you cancer. Here is a picture or a video that may work. Can we turn the lights down? I'm going to show you an actual image here, and you see if you see the cancer. See if you see anything that just grabs your attention. Did you see that? Right in here. It's going to play back the other way here in a moment. Maybe. Oh yeah, here it comes. So again, I as a radiologist am sitting there looking at the tissue saying, oh, that looks normal, it's just whatever, okay, great. And suddenly I say, hey, wait, what's that? That's called architectural distortion. That is what tomosynthesis is very good for, because on the regular mammograms without tomosynthesis, this was not seen. Here's one more. See if it goes. Oh, maybe. Again, sitting in the reading room saying, oh, that looks good, that looks fine, great, she doesn't need to come back. I'm so happy for her. No, I'm not. Little bow tie there, architectural distortion. That actually ended up being biopsied and turned out to be a small cancer. So we have lots of tools at our disposal. The clinical breast exam, important. Important to know your own breast, important to get your mammogram yearly, important to bring your priors, important to know your risk, which you can discuss with your doctor. They have lots of algorithms to figure that out. But in summary, most breast cancer is not hereditary. So even though you hear much about the BRCA1 and 2 genes and other genes, breast cancer is going to be out there regardless of genetics in a person. Your average risk, again, do your mammogram starting at age 40. High risk, you're going to need your annual mammogram early probably. If you've already been diagnosed with breast cancer, they may do it more frequently than 1 year. And you may get adjunctive tests, MRI, maybe ultrasound in there, in order to determine if you're having any recurrence. Bring your prior exams if you have them. It may save you from making an extra trip to come back to see me. Ultrasounds and or MRI do not replace mammograms. I've had people tell me, oh, I can't tolerate mammogram. And I'm thinking, can you tolerate cancer? Because that's what you may get. And know your own breasts. And that's it. Thank you very much.
The difference between, or what is the stages for getting the BRCA? If you do that, what are the stages of getting that test, and what does it entail?
Oh, getting the test? So, okay. I don't actually do that testing. The person who does is not here. But what happens is, if you end up with actual breast cancer and you're below age 40 or you meet criteria for testing, they're going to go and send off your genetic material to a lab. Then, dependent on the lab, it takes sometimes 4 to 6 weeks for them to go and they sequence your DNA basically. So they can look for the BRCA1, BRCA2, depending on what kind of little package they have, because some people have, you know, kind of a 10 for 1, you pay and we test you for BRCA1, BRCA2, P10, ATM, all those different things. And they'll tell you, they'll give you a little profile. They send it back to your doctor and you meet with your doctor and they go over. They say, okay, yes, you do have the BRCA1 or 2 mutation, or you do have this other one. And based on that, these are your risks, and this is what my recommendations are for doing something about it. Either, if you have BRCA1 or 2 mutations and you've already had breast cancer, they're going to tell you to cut them both off because it's very likely for it to show up again. Some people will find out before they get any cancer, right? Say a relative finds out that they have it, they get tested, and they'll just get what's called a prophylactic mastectomy, meaning I don't have cancer, but I'm probably going to get it, so I'm just going to cut them off. And very often your insurance will give you new ones. So, you know, it seems to be painful. I've not had a mastectomy myself, but the idea of not having to wear a bra is quite exciting. So, but that's generally what happens. They assess your risk before, they get the material, send it off to the genome lab. They do their thing in about 4 to 6 weeks, and then you meet with your doctor again to go over the results, and they give you their recommendations. Yes?
Is the increased risk when you have dense breast because they can't find it or because you have dense breast?
You know, it's listed as an independent risk factor, meaning just density by itself. Now, I've thought about that. I think in part because dense breasts have more tissue in them. More tissue gives you more things to get cancer in because you just have more ducts and glandular tissue and all that to start with, as opposed to if you had like one little wisp of tissue, your cancer would probably have to start in that. And then also, the risk is in part because people like me are looking for a white cancer and a very white breast. And again, over time, I mean, cancers don't generally start out as a grapefruit-sized anything. They start out very small and change over time, and that's why when I look at a mammogram, I go back to everything I have, and I lay out in front of me. I said, is there any change? Has this been there? Does this look the same? And with a dense breast, it's just harder. It's harder, and sometimes, well, almost all the time, if you see cancer, you can go back and you can guess where it was, but you think to yourself, would I ever say that going forward? No, because 100 people a day look like that. It just is, but it does by itself, even without a radiologist, give you increased risk. Yes.
Because I've been going for like 10 years,
Mm-hmm.
and then they never said that, and then why is it that they,
Start telling you now?
yeah, 10 years after?
Something, well, a law came out that said you have to actually inform people about their breast density, and that came out in, I think, April. And so that's why suddenly they're like, oh, you have dense breasts. And you're like, wait, did I have dense breasts before? Yes, you did. But a law came to let people know so they are informed and so that they can say to their doctor, hey, I have dense breasts. Should I be doing something else about this? But yeah, that's because a law came out.
That makes sense.
Yes.
Used to be or they used to say that when you breastfeed,
Mm-hmm.
the chances are less than when you don't. Is that still?
Yes,
okay,
it's listed as a protective kind of activity, just like having children is a protective kind of activity. I mean, in part, you have to have a child to be breastfeeding, I guess, unless you're just a wet nurse. But it's a matter of balancing out hormones in part, because your risk for breast cancer is increased the longer you have exposure to female hormones, right? So if you start your menses at like age 7, hopefully not, and go till you're 55, that's a very long exposure time. That's going to be a risk factor for breast cancer because you've had so much exposure to that. Now, if you start your menses at like 17 and at 40, less risk because you just had a shorter exposure to that. And then each child, right, interrupts that hormonal cycle of the menstrual cycle. Each child stops that for about 10 months or so. And so that decreases your risk each time. So I'm not saying you need to go have like 10 children to do that. Because there are people that still have breast cancer and they'll say to me, I have 5 kids. And I say, oh, I'm sorry. But, you know, it won't completely stop it, but it's all relative. So, I mean, you can do everything you can. You can eat as healthy as you can. There are people that seem like the healthy people on earth and die of heart attacks. You know, you never know. But you do your best. That's all you can do, and deal with it when it comes. I don't have an actual percentage. I'd have to look back, but I mean, it was listed in the greater than 4 times relative risk. Let me back up. Okay, so this is a chart. Again, relative risk. Relative is your average person. They are 1, right? So you can go upwards to 4 times your average risk. And I guess if you want to just say I don't know if you should really just multiply 4 times the lifetime risk. I don't know if it exactly works like that. But you can see it puts you up there with atypia. So it is something that's pretty risky. And it's just, you just have more tissue, and it's harder to find.
It makes it sound like high risk.
Yeah, it's relatively high risk. I don't know that you're going to get an MRI paid for by your insurance every year for that, but your physician may add a breast ultrasound in there because ultrasound is good at seeing some things that mammogram can't sometimes because of the background tissue. But yeah, if you have dense breasts, just talk to your doctor, and I'm sure there's plenty of them writing orders for ultrasounds on a daily basis that I see. Yeah.
Talked about the 2D and the 3D
Yes.
mammography.
Mhm.
So would you recommend when you're scheduling your appointment to seek out a provider who does the 3D as opposed to 2D?
I think, honestly, it would kind of depend on your breast density. If you have fatty breasts, I mean, they're pretty easy to see through. So I don't think that you should, postpone something waiting to get to a place that has 3D mammography. If you have dense breasts, I mean, it does help. But again, I can go through an entire day, see dense breasts, and pick up nothing. So it's not like every single day. And it still has limitations because if you have, imagine oatmeal congealed and is packed very tightly together, and you're looking for a tiny little pea inside of that. That's kind of what it is. You can kind of pull at the oatmeal and separate it some, but it's still much harder to find the pea in oatmeal than it is to find it in water. So if you have heterogeneous to extremely dense breasts, that might be a good idea. But again, I mean, people have been doing mammography for many, many years, and they didn't have the 3D, and they were still finding things. It's just a matter of sometimes you find it a little sooner. Like the one I showed you was invasive, but it was very, very small. Like most of that stuff that you saw coming out was just reaction to the tumor. It wasn't that the tumor was that big. So it does help find things earlier, draw your attention to things, but it's not perfect. Okay.